Welcome to the Brilliant Board Review Podcast, your trusted source for high-yield board prep, CME, and the latest in clinical medicine.
Now, let's talk about medications for heart failure. And we're going to talk about preserved ejection fraction. So what is preserved ejection fraction? So this patient's having symptoms of orthopnea, dyspnea, and edema. They have an S3, and maybe if you checked it, they'd had an elevated JVP. Their ejection fraction is greater than 50%. You can get a BNP if you want. And remember, these aren't perfect. BNP greater than 100 can be positive. Now, what would be a condition that would cause you to have a lower BNP, but they are in heart failure? Obesity can do that. And then you can check a pro-BNP if that's what you have in your system, greater than 300. Same rules apply with that. And you got to rule out other things. Other shortness of breath, dyspnea. Maybe they're anemic. Maybe they have cirrhosis and it's causing them to have fluid in their lower extremities. Maybe they're having a COPD exacerbation. Maybe it's a combination of these things, kidney failure, maybe medication-induced. What's a medication that you can take that can induce this? Well, NSAIDs. NSAIDs could possibly induce this. And then you look for the etiology. And you say, well, what can be a cause? We're learning more and more. Amyloidosis is a recognized cause of heart failure of preserved ejection fraction. They're saying about 1 in 8 cases possibly. And you look at the inciting factors. We talked about NSAIDs can be inciting it. What about other things? Well, if you notice, if you work in a hospital system, you look at the major holidays after the 4th of July. What do you eat? You eat really good stuff. A lot of people go in and say, hey, let's go to the lake and eat some vegetables. How about Christmas? When you go to grandmother's house, you go and eat your vegetables. How about on Thanksgiving? Is it a vegetable feast for you? No, you look at these foods and you think about it. How about the Super Bowl? The Super Bowl, did you talk about the vegetables that you're going to eat with the low sodium and no alcohol intake? No, these are things that you don't talk about. And that's not part of our culture. And when you go on these holidays, you look at these inciting factors. And you can look at the heart emissions for heart failure post-holidays, major holidays, and you'll see increases. So what's the medications we can use? Well, we're going to talk top shelf, then we've got the lower shelf. Just like the alcohol. Diuretics. So when would you consider diuretics? If someone's having signs of volume overload or in class 3 or 4 heart failure, and actually heart associated class 3 or 4. Now the SGLT2 inhibitors, those are starting to become worse the first line for this. Now, when we say this, because the studies, the Emperor studies, they showed just specific ones, but it's a class effect. There has not been proven that one is greater than another. It's going to be what, I'm going to say that dirty word, insurance, what you can afford. And adaptofusp and empagliflozin, those are the ones that were in the trials. But does that make them the only ones? No. Finerenone, this is one that we will have a discussion about, and you'll have more lectures on this. This is one that's popping up, and we're going to have to see how this guy plays out in the long term. Now, spironolactone, I'm just going to talk briefly on it because it's kind of controversial. It's called the Top Cat trial, and some of the things in the study, the way it came out, were some people didn't even have an increase in potassium or bumping creatinine, which is very unusual for this medication. So these are things, maybe we'll kind of just look at this, and it's a possibility. And then we're talking about our subcubital valsartan, which is a great medication, and it has a 2B indication for all women with preserved heart failure, all women, and then men with ejection fraction less than 55 or 60%. What's the side effect that costs a lot? Candesartan is a 2B indication for patients who cannot take an ARNI, the subcubital valsartan, and who maybe can't afford it, because it is expensive. And this would be an option for that. So these are medications that we can use for heart failure with preserved ejection fraction. Now, when we talked about restricted ejection fraction, we have much more. We've done a much better job in that, and we still have a lot of work to go on heart failure with preserved ejection fraction. In fact, the SGLT2 inhibitors, even though they're not going to be a game changer, they're not going to make people that are bedbound and get them walking and running down the streets, but it's been a game changer because it's one of the first medications actually shown things. Now, is there a lot more we need to improve? Yes, there is.
Thanks for listening. Visit brilliantcourses.com to learn more and claim credits for this educational activity. See you next time.